for me to represent all of you, our rector, Professor Viorel Scripcariu, and the entire community, in welcoming again Dr. Péter Hegyi among us. For most of you, I'm sure he doesn't need a lot of introduction, but I will formally kind of do it in a few words. Hungarian physician scientist and scientific innovator. His work bridges discovery science, translational medicine, and talent development. He's an educator and also scientist. He founded several very influential organizations that he also led. The Hungarian Pancreatic Study Group in 2011. Now it's a 110 institution consortium around, comprising 28 countries. The National Academy of Scientist Education in 2013, which is aiming at high school students, over 5,000 annually, which receive insight from over 21 Nobel laureates. And last but not least, he founded the Center for Translational Medicine, and that is the way that we got to know Péter here in 2016. And so far, the center has trained over 440 clinicians from 34 countries. His research is on the role of pancreatic ductal bicarbonate secretion in preventing premature enzyme activation and pancreatic autodigestion, and basically he's a pancreatic physiologist and he contributed to the change of a paradigm in understanding pancreatic physiology. His group showed that major pancreatitis-inducing factors impair CFTR function and bicarbonate secretion. And this dysfunction can be restored by drugs that were originally developed for CFTR mutations. Beyond basic research, he led multiple RCTs and also observational clinical trials in acute and chronic pancreatitis and contributed to several international guidelines that actually are now used in clinical practice. In numbers, his scientific output is over 700 peer-reviewed publications, an H-index of 82, over 30,000 citations. He received the Robert F. Pitts Award in 2025 from the International Union of Physiological Sciences, which is the highest, one of the highest honors in the field of physiology and epithelial transport physiology. Dr. Hegyi has a particularly strong collaboration with our university. 9 physicians from Iași have joined the CTM, the Center for Translational Medicine, so far. He has co-authored with them 15 scientific papers with researchers from Iași in gastroenterology and gut, for example, which for those of you in the field know, they are some of the top journals in that area. One of the last things that he did with us, for us, together with us, was to organize our celebration of the 50th anniversary of the Nobel Prize for George Emil Palade, and he was the artisan of, for us, having here Martin Csolfi, a physiologist, and a Nobel laureate for that event. Last but not least, my non-official and informal take, he's a man of vision and a man of action, and he is a great friend of us institutionally and personally for many of us, and we're grateful for that. Péter Hegyi.
Thank you very much, Radu. I wish my mother and my daughters would have heard that speech. Thank you so much. I really enjoy every minute I am spending here, and I'm so happy that again I can see many smart, eye-sparkling people in the auditoria. I always mention I visited plenty of other towns in Romania. Of course, Cluj, Târgu Mureș. Actually, my father was born in Târgu Mureș. And also Bucharest and other towns. But I never ever seen such such smart and visualized and future visions people in Romania than in Iași. I don't know what is in here, Iași. I don't think so that it's by accident that George Emil Palade was born here. I don't think so it's accident that the first university was established in Iași. So I really felt something very similar what I believe. So I will speak today about the medical field. As you know all, in medicine you always start with conflict of interest. So I would like to mention you two highly important conflict of interest in my life. One of them is I love science. I cannot hide it. I love every minute I'm spending in science. And the other issue is I really love Romania. We have students from 34 countries. We have from Romania around 20 students. And I must say that from the 34 countries, they are in the top in knowledge, for sure, if I compare with the other 33 countries. Let's start about what is translational medicine, because if I say what is gastroenterology, what is gynecology, what is urology, dentistry, even my grandmother knows it. But when I say what is translational medicine, everybody starts thinking and tell definitely a different story. So what is translational medicine? The smallest things to mention it, this is a scientific framework. One of those 3 frameworks which is in medicine. This is discovery science, translational research, they generally done in the labs, and translational medicine which is done at the patient side. So let's look at what are the characteristics of these 3 entities. As a Hungarian, I cannot bring you a better example than Katalin Karikó. She is a biologist. She was working in Szeged when I was graduated as well. And she had a scientific question, how you can diminish the T-cell immunity for RNA by changing nucleosides. And she could find if she changed 2 nucleosides in there, this actually completely diminished the T-cell immunity. So she generated actually a new knowledge, and the main characteristics were the novelty. Very important, at that stage, nobody knew the society benefit. It was just understanding the nature, nothing else. There's a huge mistake nowadays by grant agencies asking for discovery science, what will be the society benefit? Who knows? We don't know. This generates a new knowledge actually in the system. So what is the difference between discovery science and translational research? So translational research, taking the knowledge from discovery science and try to make a new option, a new tool in medicine. I am a gastroenterologist, so I cannot bring a better example than Barry Marshall, who was an Australian pathologist. He not wanted to understand the nature, he already looked at a disease, like ulcer disease, and he asked a simple question, can we have new therapeutic target in ulcer disease? And he found that there is a bacteria called Helicobacter pylori in it, and he found out the association, and he also found out that if he treats it with antibiotics, the disease disappears. The big difference between discovery science and translational research, that here you have a disease, here you have a new options for doctors. But this will again not generate immediate benefit for your patient. It will generate a possibility around 15 to 25 years. If you look at it's around 17 years, how translational research can be a general practice in medicine. Either it's a new endoscopic tool, either it's a new drug. So translational research is again done in the lab, like discovery science, but the major aim is a proof of concept that your target can work in human life. So then, what is translational medicine? Translational medicine, I am a member of Semmelweis University. I cannot bring you a better idea than Ignaz, an example Semmelweis. he hated the laboratories. He never went to do research by pipettes. He never wanted to do that. However, he was a brilliant physician. And what he saw, that 10% of ladies giving birth, they are dying. And he said it's unacceptable. And he also put a hypothesis that why at the university clinic 10% dies, and why in a non-university clinic 1.3% dies. And he had a hypothesis that these doctors from the pathology department, from autopsy, they take something, microorganism, inside, unfortunately, to the women when they investigate them, and there will be a fever. And he is considered as one of the first antiseptic procedure, what you do now, guys, every day when you do something, even in dentistry or gynecology. And he said he had a theory, if you wash your hand in a chlorinated water, then this will work. So he didn't discover new options. He just chose among the tools around him to change the outcome of the disease. The big difference that these research are done by mostly healthcare professionals and help you to understand the safety, effectiveness, and of course costs as well, because these are the three major things. And the beauty of translational medicine, that it's immediately change your management of your patient, the management of the practice. So here is a three summaries, the three part. I put a red line. Before the red line, this is done in labs. So somebody who like being in the lab, discovering new knowledge, discovering new options, let's go to the lab. But those healthcare professionals who don't like labs, but would like to do good research, then let's stay next to the patient side and use the clinical data. Okay, so why this system doesn't work fluently? Because people underestimating what they don't do. So politicians usually underestimate the discovery science. They say, come on, these are just academic guys doing some Lego playing in the labs, and the knowledge is not useful for the society. They don't even know that what will be the benefit, so why should I give money for them just to play with a toy in the lab? This is completely wrong, because if you don't have a new knowledge, you cannot generate new options, and you cannot change the patient's care. What is the real problem in translational research? We put lots of money in it. However, the transition from your discovery to companies to have a product to sell, there is really a stuck. We call it the Death Valley of innovation. If I go to Hong Kong or you go to Shenzhen, South China, if you go with $10 to the court, within 5 minutes you come out with a company. They even teach at university students, if you have an idea, let's establish a company. In Shenzhen, South China, there are 20 million people lives, every fifth of them has a company. Of course, it doesn't mean that this will be successful. Most of them are going down. But some of them, which have a product, then they can rise. What is the problem with the third one? The third one is usually underestimated by academics and universities. Ignaz Semmelweis never ever be a member of the Hungarian Academy of Sciences because they said that you cannot discover hand washing. So academicians said, no, come on, it's not. Many universities prohibit to have data science in PhDs, like meta-analysis, network meta-analysis, registry analysis, because they say only newly generated data count. But last time, from the 5 Nobel Prize, 3 of them were given, even what we use ChatGPT, for a discovery which never used a new data, but used an already generated data. Now we have a cloud, and not only rain comes down, but also data can come down, which were not existed in the last century. Let's use it. And this is what actually they do. The other things, the the healthcare authorities underestimated because they say that the resident doctor need to be 100% with the patient. And those doctors will be the better doctors who spend more time with their patients. However, this is not true in the 21st century. I will show you direct evidence that having a scientific knowledge will improve your patient care. Now, at Semmelweis, we could change actually the system. So usually the big difference that the first one is done by scientists and the other is healthcare professionals. Okay, now we have some understanding about these three frameworks. And one of those, actually the translational medicine can immediately improve patients' care. We have medical training. We have tremendous amount of residents. I just learned that in Yash you have over 2,000 resident doctors, 3,000. Oh my gosh, at Semmelweis we have only 750 resident doctors. So you have almost 4 times more resources among brilliant young people that we have at Semmelweis. So they have a resident training when they learn the difference between expert-based techniques, evidence-based, personalized-based. So what if we would put this together and not any longer students need to choose between science and residency, but you can choose both. So what have happened if we do that? I am very proud that I am a member of Academy of Europea, and actually we always look at statistical data because, okay, the idea is here, but do we have an unmet need to do that? Last century, the biggest problem in medicine was that we had no new results, new knowledge. In the 21st century, unfortunately, the problem is not that we don't have new knowledge, the problem we don't use it. This is the problem. If you look at this European data, under 75, 1.7 million people die, but 1.2 million people's life could have been avoided. Deaths with better prevention or treatment. Prevention, smoking, alcohol, so on. So we need to teach the society as well. But the other is the management. 3 of 5. In those countries where the scientific activity is not too high, this is even worse. Unfortunately, Romania and Hungary, they are the top athletes in the world on it. It's around 80%, which means every 4 citizens in Romania's life could have been avoided and saved from 5 if we use all the knowledge which were generated in the past. So what we need a new thinkers, healthcare professionals who are using the newest scientific knowledge. So if you put this together, you can have the young doctors to get residency and PhD together, but very importantly, your patients will heal better, and your university actually can grow with scientific output. And if you do your research in a high level, and this is put in a guideline, therapeutic management guideline, then everybody in the world can use your knowledge. And as I mentioned, I am really proud of being member of Academy of Europea, and we put a project in translational medicine that we want a better transition from the discovery to the real life. And in the last 5 years, I was working with over 400 clinicians and translational researchers. The Ulrich Hirsch index is 88, I am still below. And 35,000 early citation of these 400 guys, and the whole academy, including 92 Nobel laureates. So the knowledge is quite good. And we could build up this educational system which helped the healthcare professionals to grow. Usually we say, if you have a good vision, but if you cannot write it in a business card, it's not ready yet. So within 10 years, we could have a very simple vision from science to society. And this is the vision of translational medicine. And here I show you 3 evidence that your patients will heal earlier than the students receive sometimes the PhD degree. So one of the examples was that this program started in Pécs when students came to Pécs, a gastroenterologist, and asked a very simple question: why do we use 80% of acute pancreatitic patients antibiotics. I mean, it's an inflammatory, not an infectional disease. And we could understand that in the early phase, there is a high rise of CRP level and leukocyte level, which actually mislead the doctors. We could publish a new way of deciding the antibiotic usage, and published it. Next year, the resident doctor, like all of you here, went back to the ward and started using the new techniques, and they measured in the hospital before and after the antibiotic usage. And they could decrease the antibiotic usage with 31%, and the hospital, length of hospital stay with 164 days. The resident doctor defended her PhD in year 3. Another example, a pediatrician treating cystic fibrosis disease. The parents took the kids at year 10 to the department with visual impairment. And when they looked at, all of them had CF-related diabetes. So again, they ask a very simple translational medicine question. Why don't we start screening them at the age of 4? They started it. And within a single year, they could identify 30% of the kids with abnormal glucose tolerance. They put them on therapy, and after the 4-year follow-up, didn't come any visual impairment for them. After that, she defended her PhD. Okay, there are plenty of surgeons, must be here as well, who want to be a surgeon. Is it okay, also in surgery? One of the hospitals, Kata Illés, asked the simple questions. Cholesteatoma is a benign tumor of the air, but always when you operate, there is a recidive coming back. The recurrence rate is quite high. So she asked a very simple question: what could be the new operational methodology which can lead you a less recurrence? They not only find out a brilliant meta-analysis that this is the mastoid obliteration, but then they published. Next year, they went back to Bajcsi Hospital, which is not at Semmelweis, so these 3 examples are not at Semmelweis, and started using this new operation. And they measured in the hospital record the recurrence rate before and after it, and it decreased with 13%. The 3rd year, Kata defended her PhD. The beauty of translational medicine that you guys can see that your patients heal better. So I did plenty of discovery science, but I always wished I see at once, I want to see my patients to heal better after my research. After I went to translational research, I did a lot. But again, I said that I want to see my patients heal better. Now I enter to the 3rd stage, and I love it. To be honest, when I love it, that I see something, publish it, I start using it next day in a clinic, and I can see that my patients heal better. This is really translational medicine. And how you can judge your program. Okay, I love it. I cannot pretend it. But how you can judge it works. In Hungary, usually one university has 30, 40 PhD positions per year. It was the same at Semmelweis. So we went to the ministry to give more places, and within 5 years, 434 healthcare professionals, mostly PhD students, joined from 34 countries, more women than men. And most of them, if you look at the age levels, they were resident doctors. Here are the countries. And as I said, I am so happy that we have many students from Romania. You will listen a couple of them here from Yash at the end of my presentation. And there are many, even from the US, we have one person. We started a new group in Vienna. So in Vienna, we have a same group. And your university actually is in the 2nd position. And I hope we had a very fruitful discussion with your rector and directors and vice rectors, that hopefully we can have something similar program in the forthcoming years also in Yash. I was very proud that we had from NYU, from New York, from Manhattan, we have a resident doctor came over for this program. Never ever happened, this one in Hungary. And this is showing that these are not the same people who are going to the labs. These are the ones who are at healthcare professionals, but not only medical doctors, dietitians, psychologists, physiotherapists, pharmacists, so everybody can join who has a master degree to the program. And here are the publications we could publish, in recent years. The other really key performance indicator for me in science, not only that how many students choosing it, but also where we can publish. If you look at these journals, these are really top journals. Of course, when we started at Semmelweis, people asked, come on, Peter, you are in the middle of Central Europe. This could be a wish, but never can be done. And it could have been done with a good program. And I show you that not only we can do, you can do it. Any of you who are sitting here in the room can publish these journals. So I had the privilege to work with 9 students from Yash, and look at the publications they have. And we have brilliant supervisors like Vasil, who is sitting here, and also with Diana, and they could publish brilliant articles in the #1 GI journal. Or if I look at, other articles in a main journals, who are doing guidelines. Or look at Bogdan. He is one of your pearl, I would say, in translational research and leading CEMEX lab tremendously brilliantly, even from Budapest. We can see his work. They also could publish with Joanna and Irina tremendous papers. So your supervisors and your students are at the same quality like we have at Semmelweis University. And we have here Victor as well. I could see him also in dentistry. You can come with really top articles. And not only they can publish your students with the brilliant supervisors like Bogdan, Vasil, Victor, or the others, but they also can publish with other international programs, with Vienna and with Semmelweis. So Diana has really brilliant articles. She just defended her PhD at Semmelweis in top journals. Also Madalina has many other articles together. And I think this program is giving a new platform, a new possibilities, a new options of your next generation of scientists. And also we can involve your supervisors who are really, really brilliant to other international top science and top articles. So you can open up the opportunity for people in Yash, if you're doing something new methodology to go together. And if you can provide evidence for your government, this can be even more helpful. In Hungary, we could go to the Ministry of Health and to the Ministry of Education and change the system. Now at Semmelweis, a resident doctor can choose to do full residency or 50% residency, 50% science. And in the second form, they earn the same amount of money. So this never happened in Hungary before. This is a change in laws. I have no idea how many students we will have. Until now, we had 90. I checked the number of students applied for a position. Now it's 3 times higher than in the same time last year. So I don't know how many students we will have, but this can attract them. So how the program look like? What is science? You need a project. You need the students and a supervisor. This is how now a regular way going. Let's look at a daily example. What project can be suggested as a daily example? I can see many guys and many ladies here, so I will ask the guys now to work a little bit. So the project will be to change 4 tires in a car. So you can see easily who is the supervisor and who is the student. Guys, you can see it very visible. So how long would you change the tires? Tell me a number.
All the tires?
All the 4 tires.
If they're already on the wheel, half an
Half
hour.
an hour? Okay, what is your name? Theodore. Ladies, write down Theodore's phone number. If you are stuck on the road, Theodore will go there, and within half an hour, he will solve your all problems. So Theodore can be reached after the talk. You can go there. But my question is it really the best way to change 4 tires? This is the most effective. Do you like watching TV on Sunday afternoon? Formula 1? So I am not sure that Theodore's doing the most effective way. Theodore is brilliant because he's enthusiastic, but I am not sure he will do it. So who knows the world record of it? 1.8 seconds. The same project, 600 times different, almost, or even more, the outcome. The only difference are in this picture that people work as a team. So science is not a one-man show any longer, and they use the newest technology. And the effectiveness can be unbelievable. So can it be done in a PhD program? Yes. Take a student who has enthusiasm, has time to work, they don't have a clinical knowledge yet, they don't have a biostatistic knowledge but they have a dedicated time and the driving force to do the research. Let's choose somebody else who needs, because they don't have a clinical knowledge, so you need a top clinicians like Vasil, like Victor, or the other top clinicians here, who can tell what is a good question next to the patients, like Semmelweis Ignaz did. But this is enough, not because you need the Ferrari team around you, and you need informatics, biostatisticians, legal person, GDPR, methodology experts, and all of this. And we not only teach any longer only science for the students, because science knowledge is not enough. You need to generate, you need to educate the next generation of leaders at your university, which are definitely coming from those who do science as well. If you look at how to go up, so we teach leadership, we teach time management, we teach adaptability and flexibility, we teach crisis management before the exam starts and you have only 6 hours left, before the exam. We teach how to write an article, we teach how to write a grant. All students writing the articles in a quality that only 10% of them could have been reviewed extensively by the supervisors, because they go under the program. Usually in the first 3 months, actually we teach them how to ask a question only. They need 2 questions to write. After the data collections, data analysis, article writing, usually until now with the 9 students, they spent 1 year in Budapest and 3 years in Iași. So this is a co-tutel program, a bilateral program. However, it seems more than likely that we can start an own session here in Iași. And we need 2 first author papers, at least the 5 impact factors of that. But if you look at the journals, this is what we have for all students. What is the curricula today in the PhD? That the students working with the supervisors, and 3 months before the defense, oh my gosh, we need credits as well. Let's go to somebody, sign in the credits, because I not only need papers, but I need credits. And this is not very well organized, in many health, what to take, which credits to take. Here, we not only teach the different things, but we know why we teach on the same week, why we teach, and why the students will need it. So we put a coherent program, like in medicine, like Vasil knows what to teach in 12th of September or 15th of November, already at the start of the year. In this program, we design the education as detailed as before the year, than like in gastroenterology. And here is the output of the program. And if you look at, we have so many new video recordings and new educational type. We run 10,000 online meetings per year now for the 400 students. We even have Nobel laureates coming to visit our programs and giving talks. And also, if you look at the outcome, tell me which outcome I am the most proud. Who will tell first?
Number of people?
No? 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 What was? No? Guideline. That all 500 articles, 158 are published in international guideline, and the knowledge we generated in Budapest are used in Tokyo, in Belfast, in London, and in New York. So I think 30%, this is a really, really suggests that the knowledge is not for you. The knowledge actually is for your patient. And I would like to show you a short video, if you can start, how the Nobel laureate thinking about your program.
Science is an indispensable element of progress and the future. Science changes lives when discovery leads to action. The National Academy of Scientist Education makes this happen through 2 programs. The Discovery Science Program, which focuses on nurturing future researchers, and the Translational Science Program, which turns knowledge into real-world applications.
I think the development is fantastic. I mean, when I came first time, it was a program centered in Szeged, with students coming from different parts of Hungary. But meanwhile, the program has developed into 2 branches, and actually one of these branches aims at revolutionizing science education in all of Hungary.
Science really knows no boundaries. The important thing is that, you encourage it, you nurture it, you recognize it, you foster it. And this program surely does that.
I don't think you can be a good physician today without understanding science, without doing science at some time in your life, asking questions, critical questions, analyzing the literature.
The Translational Medicine Hybrid PhD program, launched in 2016, aims to provide healthcare professionals with the knowledge essential to translate scientific results to their patients' benefits. Since 2019, around 100 students, including doctors, dietitians, psychologists, and economists, have defended their PhD theses as part of the program. To date, more than 400 PhD students and 250 mentors from 36 countries have joined the international program. Recently, the program has accelerated significantly with the support of Semmelweis University, the government of Hungary, and Academia Europaea. Healthcare professionals have been able to demonstrably improve the quality of patient care in a short time, which, in addition to its positive social impact, has also resulted in cost-effective patient care.
If they choose to develop career in science, they will have the view of the entire distance between the patient bed and the route to try and cure and help and develop drugs like we do.
Besides the several professional and social events, students of secondary schools and universities, as well as healthcare professionals, can attend the meetings of Nobel laureates and talented students, which are organized by the Academy twice a year. At the conferences, approximately 4,000 guests, pupils, students, mentors, doctors, and other faculty members can listen to scientific presentations of professional quality, participate in educational events, and meet or talk to Nobel Prize-winning scientists and internationally renowned researchers. Since the first meeting in 2012, the Academy has held 25 successful conferences with the prestigious participation of 21 Nobel laureates hailing from different parts of the world.
This program is new to me, so it's actually the first time I actually see Nobel Prize winners and other prizes winner to come close distance, almost one-to-one, to talk about their work with the students. So I think this model is very ambitious and very, very good.
First of all, I have a tremendous admiration and inspiration by what is done here to this program. This program is unique around the world. It's very special. It's not only going to improve Hungary, it's going to improve not only Central Europe, it's going to be a motor for progress, innovation, and a better world around the world.
The capital that you are building through this program, human capital, social capital, and potential economic capital, this is a great investment. And I really think that every country should have programs like this, and I think that you should invest as much as you can afford it.
Yes, and I also would like to say that also as your vice rector mentioned, that I had the privilege to be here, and because I'm a pancreatologist, it's even bigger privilege than giving in this auditorium again, because like George Emil Pallad changed the whole landscape of thinking about molecular cell biology and the electron microscope it was. And I remember my first time when I was here with your rector and give my first talk. And really that I could be part of this story, that was tremendous for me. I mean, my wife was very unhappy because the same time we had the meeting of the American Pancreatic Association in Hawaii. No, today, I should have been in Alicante in Spain, but in both she wanted to come, but in both times I chose Yash, because for me this scientific celebration for George Emil Pallad was even brilliant, and I really like that Martin Chalfie, who is one of the top researchers from the US, could come over here, and we're here. So what I really wish to have a fruitful collaboration, but most importantly, I think now 3 of our students will give a little speech about how they feel about the program and what they did. So therefore I would like to give the stage to you guys, first to Roxana, to say what is their experience in the program, because I think it's okay what I am saying, but maybe to listen from them, it will be even better. Roxana, the stage is yours.
Thank you for the nice introduction. Okay, so distinguished guests, dear audience, it is a great honor to be here today and have the opportunity to present you my journey at the Center for Translational Medicine. Okay, this one. I will briefly introduce myself. I'm a gastroenterology resident doctor and a PhD student in the bilateral program between our university, Nyash, and Semmelweis University at the Center for Translational Medicine. On this slide, you can see part of the amazing team I've had the opportunity to work with since September 2025. And I have to say that I'm deeply grateful to my supervisors, Péter Hegyi, Cătălin Svarti, and Stefania Bunduc, for their continuous guidance and support. Regarding my research area, my work is mainly focused on the early diagnosis of pancreatic cancer, with a particular interest in improving diagnostic strategies. Now that you know a little bit about me, let me tell you how it all started. 2 years ago, I attended a conference just like this one. I was sitting in the audience listening to Péter Hegyi and other PhD students from the Center for Translational Medicine talking about research opportunities and the PhD program they provide. At that time, I was still a 6-year medical student and everything felt distant. Today, I'm standing here as part of that same program, and I want to tell you how that transition happened. After that initial moment in March, things started to take shape. First of all, I was admitted as a PhD student in Iași at the gastroenterology department under the supervision of Professor Svarti. A key moment came in December when I first met Professor Hegyi at a symposium during our university days. That was actually the first time when I told him I was planning to come to Budapest. Last year, in January, I've started my gastroenterology residency, which marked the beginning of my clinical training alongside my PhD journey. It was a very exciting step, but I have to be very honest with you. Once residency started, my time for research was almost non-existent. And that was the first moment when I understood if I want to take research seriously, I have to change something. So a few months later, I applied for the bilateral PhD program, and I went through the interview process, first in Iași and then at CTM, and fortunately, I passed both. At the end of last summer, I moved to Budapest for 10 months, and I started a completely new chapter of my journey. Looking back, each of these steps felt small at the time, but altogether they completely changed my path. Since September, I've started working on my 2 ongoing meta-analyses, and this was the moment when research became part of my daily routine, not just something I was trying to fit in whenever I had time. But what motivated me to trust this program? First of all, how well structured everything is. At the beginning of the first year, I received a clear schedule and a checklist, so I knew exactly what the requirements were, what I had to do each day, and what progress is expected from me. Another important aspect is the strong mentorship. At CTM, you have the opportunity to work with excellent experts who can guide you as supervisors, and at the same time, during your weekly meetings, you meet specialists from different fields who can share with you their experience and provide constant feedback. Teamwork is also one of the greatest strengths of CTM. You are not alone in this journey. Besides your supervisors, you are supported by a much broader team, including your scientific methodology supervisor, your statisticians, your co-investigators, and your students who can help you with your daily research work. Another important point is the international collaboration. This program allows you to meet people from different countries, exchange ideas, and expand your professional network. But most importantly for me, I was inspired by real examples. I saw the journey of older colleagues. Diana Floria, for example, who's also a gastroenterology resident like me, who soon to be a specialist, who just defended her thesis 2 weeks ago in Budapest with great success. So in the end, I can say I was inspired motivated, not only by the structure of the program, but also by the people behind it. I hope that through my presentation, I was able to share with you a meaningful perspective of my experience. And with that, I would like to end with the words of William James, a quote that keeps me motivated every day. Act as if what you do makes a difference, it does. Thank you very much for your attention.
Good afternoon, everyone. I would like to start my speech by saying that I'm grateful for this opportunity to stand in front of you today and to present my pathway within the Center for Translational Medicine. To briefly introduce myself, my name is Darius Valentin Sandu, and I have started the PhD program, the bilateral PhD program between our university and the Center for Translational Medicine in September 2024. And today I would like to present my pathway within the Center for Translational Medicine and the opportunities that this program has created for me. How did it all begin? Again, March 4th, 2024. This was the first direct interaction with the translational medicine concept. I was a 6th-year student when Professor Hegyi came and held a workshop which was pretty similar to this one. Well, I'm not the best photographer, but here in the bottom left corner, you can see Professor Hegyi presenting, during his presentation, passionately talking about this new model of building and creating better researchers, which ultimately would become better clinicians. I must say that that day represented the cornerstone in my academic and research pathway, because it was the first time I was introduced to this philosophy, and I realized the importance of integrating high-impact research with clinical practice. Now that I have presented how I got into this program, please allow me to introduce my team, who has supported me from the very beginning up until now and will continue to do so from now on for sure. First, Victor Vlad Costan, Professor of Oral and Maxillofacial Surgery, and my other 2 supervisors, Gabor Gerber, the Dean of the Dentistry Faculty, and Gabor Varga, who is the Vice Director of the program. And of course, my projects could not have been pushed through without the thorough support and guidance of my methodology expert and statisticians. So as you can see, one of the greatest CTM's strengths is the multidisciplinary collaboration between supervisors, clinicians, statisticians, and methodology experts. So we created the basics of our research direction, patient-specific implants, which is a very hot topic in craniomaxillofacial surgery at the present time. Patient-specific implants belong to the personalized medicine concept, specifically tailored implants for patients, which are digitally planned by using cutting-edge digital technologies. So we came up with two projects. The first one comparing the patient-specific implants versus splints in orthodontic surgery, and the second one comparing the patient-specific implants versus stock implants in post-traumatic orbital reconstruction. Both of them conducted by the methodology of a meta-analysis, where the first one is under review. Actually, I have just received the reviewer's feedback this morning, and the second one is ongoing. As a first-year PhD student, I had also the chance to present my research activity to prestigious events in maxillofacial surgery as patient-specific implants conference in Bruges, Belgium, and the National Congress of the Italian Society of Craniomaxillofacial Surgery in Naples, Italy. And these events not only allowed me to disseminate my research activity, but also to get to know people and strengthen my network. As you can see in the middle picture, Maurice Mommerts, professor of oral and maxillofacial surgery from Belgium and past president of the European Society, and Elias, my colleague from Germany. Besides that, I had also the chance to attend these prestigious scientific events featuring Nobel laureates such as Danny Shechtman and Tim Hunt. So these events, as Professor Hegyi already presented, are happening twice per year in Hungary, and students are attending and have the chance to learn from their academic pathway and their lives and actually engage in one-to-one discussions, which is amazing. Outside CTM, we also have time for fun and leisure. Challenge Day, a day dedicated to a bike trip around the Lake of Balaton, which is roughly 210 kilometers, and we managed to do this last year in August in roughly 16 hours. Gatsby and Halloween parties, and brainstorming weekends in Vilan. And the last lines of my presentation are about something that I consider it very crucial in my personal and professional development, because this ladder actually represents my pathway within the Center for Translational Medicine. Because I have started as a PhD student, and currently, besides that, I am also working as a scientific methodology supervisor, guiding now PhD students throughout their PhD journey, and providing them methodological advice. And these are the students who I'm currently working with, 15 students from different backgrounds, different specialties such as dentistry, gynecology, urology, pediatrics, different countries such as Hungary, Romania, Cyprus, Iran, United Kingdom, all of them having clear visions and missions and wanting to improve the healthcare system. And of course, the other part of the team, which is represented by the supervisors, again with different specialties and backgrounds, and last but not least, the biostatisticians who are working on these amazing projects. And with that, I would like to thank you very much for your attention and tell you my favorite quote: "The future belongs to those who believe in the beauty of their dreams."
Good afternoon, everyone. Thank you for being here. My name is Ioana Creangă Murariu, and let me introduce you into my PhD journey into translational approach of cannabinoids in oncology. I am a clinician learning how to think as a scientist, to ask the right questions and to explain mechanisms. But my mission has always been the same, to improve the quality of life of cancer patients with the use of cannabinoid-based medications. Cancer mortality is decreasing, so quality of life becomes as important as an efficient treatment. Cannabinoids are super popular among cancer patients, but they lack clear indications, and the literature behind it is increased in heterogeneity. We started this PhD with the question, not if cannabinoids work, but the real question was what must be demonstrated before they can be considered meaningful in oncology. And we wanted to check if they have benefits for cancer-associated symptoms, if they can modulate the tumor biology while being safe enough for patients. And nevertheless, if the literature behind it and the experiments behind it are strong enough in order for the translation into clinical trials. We planned our PhD in 5 different studies. The first 2 studies were in vitro or cellular base. 1 was in vivo or animal base, and 2 were meta-analysis. The preclinical part of my PhD was performed here at Chemix laboratory, where we did find very important strong signals that cannabinoids can work for pain and for cancer. And the results were linked between the in vitro and in vivo findings. For example, pain thresholds were restored to normal after chemotherapy-induced peripheral neuropathy, suggesting a benefit for this type of pain. Moreover, we could see that the metastasis rate of the tumor-bearing animals was lowered for those who were treated with cannabinoids as compared to the controls. Although we have some promising signals, we need to interpret these findings cautiously because one model does not represent all patients. And the results, these effects may vary based on the compound, the dose, the timing, and the tumor context. And nevertheless, clinical value must be tested against broader evidence. So these findings supported translational research, but yet not direct clinical implication. And that was the place where we decided the meta-analysis was the next tool that would help our project because translations need accumulated evidence and not only isolated positive findings. And meta-analysis transforms scatter results into an evidence map because it assesses consistency and heterogeneity and bias and identifies signals strong enough for future studies. My question at that time was if meta-analysis can help us decide if this effect that we saw in preclinical research was reproducible, meaningful, and ready to move closer to patients. And that was the place where we found out that the Center for Translational Medicine exists, and that place can help us with our next projects because they combine theoretical knowledge with academic culture and gather together teams of experts who continuously strengthen the project through clinical insight and methodological guidance. It was the place where I learned how to properly do a meta-analysis from literature search and data extraction and how to actually interpret my own findings. And nevertheless, they encouraged free academic discussion and welcomed new ideas and created a space where innovation, critical thinking, and scientific curiosity was appreciated. Another important skill I had to learn during my years at the Center for Translational Medicine was how to communicate my research findings, because presentation skills were challenging at the beginning. They still are. I hope you cannot feel the tremble in my voice. But that's presenting all over again at the Center for Translational Medicine gradually made scientific communication more natural. And I finally understood that communication is part of the research because science only becomes useful when it can be clearly explained, discussed, or sometimes challenged. During my stay at the Central for Translational Medicine, we worked at 2 different projects, 2 meta-analyses that help interpret cannabinoid signals beyond our isolated experimental findings. And we did find indeed benefits for pain of cancer patients, however, with the cost of very important psychiatric and neurological side effects. We did see indeed anti-tumor activity in case of glioblastoma preclinical models, but there were some signals with pro-tumoral activity for colorectal cancer models. The results of this PhD gathered implications for practice and for research. Cannabinoids are not universal solutions. They may be potential therapies for defined indication and patient context. And there is a constant need for high-quality research with robust design, transparent and reproducible methods that measure outcomes that are meaningful for the patient. The goal is not to produce positive results, but to generate evidence that can genuinely impact the patient's life. During my PhD, I also had the opportunity to present my results of very prestigious international congresses, for example, the World Congress on Pain or the European Society of Medical Oncology Congress. We also managed to write 5 articles, soon to be 6, because the last one was accepted last week, in very important journals with good impact factor. In conclusion, I believe that research still needs clinicians asking why, because every unmet need, unexplained symptom, or treatment limitation can become a research question. And negative results are not a failure. They refine the next experiment and make the science stronger. And do not forget that progress grows through mentorship, collaboration, and multidisciplinary teams. As a take-home message for the students, find your mentor, because research grows through people, not through protocols. And I was lucky enough to meet mentors here in Iași, but also in Budapest, that made me and my project shine. So good luck, everyone. Thank you.
So I think the best is now you have asked questions, if you have any, and I think the best is I give the floor for the students first to answer if you have any questions concerning translational medicine, concerning the program. So let's come up with the questions. There are lots of young people here who might be a fellow of future translational medicine.
Then I will give the floor to my colleague.
Thank you, first of all, for choosing Iași instead of Hawaii or Spain. No, but it's a great thing to have you here again. I attended your talk when you came last time, and I really enjoyed it. So I really wanted to be present. If you had to do a TikTok video with 3 or 5 things that you would give as an advice for doctors who want to choose a question that they want to implement in a translational science project in their clinic, what would these advices be? Thank you very much.
Can you hear me? Okay. So I believe your mentor is the best resource you can have. Of course, you can check the guidelines, because guidelines clearly say what are the gaps in the literature. But I believe experience of a, let's say, older, more experienced supervisor can give you the best question you can dream of.
And also, I think many times, it happened during project that I have been working in, that the actual results of the meta-analysis were different than the guidelines, than what other authors were saying. So it's exciting.
For us, for our project, we thought about what is the most important thing that can change the actual practice. And for my project, for example, we thought that the 5 years survival rate for pancreatic cancer, it is much better for the first stage when the tumor is less than 2 centimeters. And we didn't find in the actual guidelines something specific what is the best imaging technique to detect the tumor when it is so small. Of course, for larger tumors, the techniques are very like you start first of all with the CT and then you go with the other imagings. So basically, the best thing is to find something which can really change the actual practice.
I may be a very challenging, like, do you accept that 95% of pancreatic cancer people die?
If you think you have a loved one and you hear this.
Do you accept that within 5 years we cannot do anything? Then ask your question. Come here and try to answer and try to help these patients. I think all of you have every day question which you cannot answer. There are no limit of questions. Oh, everybody asks me, come on, Peter, how big your center would be? You have 917 studies. How you can grow? I said, until we still have a question in a daily practice, we can go on.
Thank you very much.
Well, thank you very much for the energy you put out today. You, Péter, first, and you, three. I would like to ask the guys something. Not you, Péter, because we talked about it. You've done a lot for yourselves. You've done a lot for the University of Semmelweis and the CTM. You've done a lot, obviously, for our university. What can this university do for you from now on? What do you expect? What do you expect? How do you see yourself growing at the University of Medicine in Iași together with Semmelweis? What we can do for you?
I think the best thing is to continue this collaboration with the Semmelweis University. It is very important to send more students because this is the only way we can create like a community here, because there we were taught some techniques that now we want to put in practice back home, but we need more people to have the same knowledge as us. So in this way, it will be much easier for us to communicate what we've learned there for the students here. I think for me is this one, for having the right people here as well.
Yes, I totally agree. And I think it would be great to create as well this basis here and start teaching and learning people how to do like high impact research and not only meta-analysis, I would say, because besides that, actual clinical research is also very, very important, because I don't know, maybe in 50 years we will run out of clinical questions. So maybe we won't have them in 50, I said. But more important than that, I think it's also having registries. So clinical research. Maybe each chief of department could say, like, we have this type of patients, we can extract this data, and this can be used many years and for many projects and many articles.
So for me personally, I have the same plans as my colleagues because I want to get Peter's legacy, to bring it here. I already started it, kind of, because I'm working with some students of mine for their own thesis, for the bachelor thesis. There is a small number of students yet, but I believe that together we can make this in a very organized manner and have the same impact as, maybe not the same, but quite as the same as Peter has with the Center for Translational Medicine. Because we are enthusiastic, we do have the knowledge, and I think the students in Iași are on the right path also.
So I think now in Yash you have 9 brilliant students. No, it's only 3 here. The others also here and cannot be 9. They are different persons now, I guess, and they can start something special. So now if your university decide to have your own center, these 9 students, if they get the approval from you and the trust from you, we can come here to help, and we can build a community here. You have 3,000 residents. If every year only 1% of the residents join in, just 1%, this will generate within 5 years 150 clinicians, healthcare professionals thinking differently and providing the knowledge. In addition, this program is running now in Vienna, MedUniv Vienna as well. I mean, there is a direct flight between Yash and Vienna. So in Vienna, they also collaborating with Semmelweis University on the projects. So if you here have 30 students start, we will connect them with the Vienna team. We will connect them with the Semmelweis team. They will also be with projects. So it means for 30 students can generate not only different people in Yash, but the outcome will be 3 times higher because you will continuously publish with the PhD students in Vienna and with the PhD students in Semmelweis. So having 30 talented young students, and all of them were talented, this was surprised me, then it means like 90 PhD students because they will involve in the other ones, so your university will be mentioned them. When we started at Semmelweis, we were alone. Now the program is running in Vienna, at Szeged University from September, Pécs University, even a big hospital in Szombathely will start, Vienna, and if it starts in Yash, you can change the landscape in Romania for sure.
Thank you. I share your enthusiasm because I've seen this program working in other parts of the world, and the results are amazing, and I think that it's a way to go. I was wondering, it's a question that can be translated into research proposal. Did you try to match the cohort of students that they finished this program with similar students that didn't have the opportunity to publish meta-analysis in terms of the, let's say, impact factor of their clinical research papers? We put the meta-analysis away and we only look on the clinical research that they've done after, because I'm sure that you will be a nice surprise.
Yeah, I was surprised because I felt first that the meta-analysis will be the most cited and highest impact, but not. So if you go on PubMed, looking at 100 meta-analysis, 100 registry analysis, 100 research, all of them, the average will be the same. I was surprised because I predicted that these research will be higher than the earlier one, but it's really not. So all of them, the question is the quality, and the question is how you ask the question. If your question, your conclusion can change the management of the patients, this is the key factor for a JAMA, Lancet, New England, or other journals, not whether it's what is the methodology. So a top journal thinking, your paper change the management or not change the management of patients, as simple as. Irrespectively, you prove it by your own cohort, a published article, or like the UK database, or whatever. The major thing is whether, how Joanna also showed there, it is changing in practice. You never know it before you start your research. There are articles now published in Top when the question was asked, oh, we will not be able to answer this. And after we could. So the major issue is to think, to ask a good question. And if the question is good, your methodology is strong, your students enthusiastic, you go to the top journals. And the reason why we do so many meta-analyses and not other data analysis is the problem, the electronic clinical database in Hungary. I think you have the same problem, that it's not like you don't have, you know, the different like electric system that you collect the data uniform way with variables when you immediately can start analysis. The problem in our cohort, we write the patient report in a page and so on, and this is not good currently for data analysis. So we developed an electronic clinical data platform now, which we can share also with Yash. And if we start putting together with these 6 centers, the data in gastroenterology, the data in cardiology, then this will be, I think, a huge change. And we need to find out new things because AI, you know, is just rushing and take our job. So however, what AI doesn't know well, to ask really a new question. AI is very good to perform what has been in the past, but AI will not ask a new question. The new question will be asked, I think by the clinician.
Thank you.
Hello. So I understand that you are resident doctors assigned to hospitals here in Iași. Is that right?
Yes.
So how does you signing up for the CMT program affect your residency curricula back home?
Well, we needed to be there in Budapest for 10 months, so we froze our residence contract. And personally, I went back to my resident life 1 year after. And I did not lose anything, trust me.
Okay, that's really cool. So you froze it, so it only extends your curricula back home by 10 months? Is that right? Oh, okay, that's great. And after those 10 months, you can continue your PhD from back home, so you just come back home and go on?
And we are continuing to have the meetings and the workshops, but it is mainly online.
Oh, wow, that's convenient. All right, thank you so much.
The only thing is that you will have to go back to Budapest 3 times, if I'm not wrong, or 4, to be at the progress report. So every 3 months in the first year, you have a progress report where you go and you present your team project and your results. And for example, I will come back at the end of June, and in August, I will have to go back to Budapest for 2 days to be there and present my project again. And then in the second year, you will have 2 more progress reports. One, the first one, and the second one, which is the complex exam. So after the complex exam, if you are done with your 2 projects, you can also defend your thesis, so finish the PhD.
So you're also encouraged to go on 3 city breaks a year. That's really cool.
Yeah, and financially, we have a new change, which hasn't been yet with these guys at that stage. So Semmelweis is paying approximately 20,000 euros for you guys as a scholarship for 4 years, which is not bad. So you even get the money when you come back, every month 400 euros. However, after the complex exam, you can defend your PhD. And based on the new regulation, if you defend your PhD, you will get the full rest of the amount in one payment. So now we have students who had 2 papers within 2 years, defended the PhD and received 8,000 euros netto on their bank account and the PhD degree. And this is something different than were before. So Semmelweis is giving money. I know that the university here also support you. And altogether, I would say it's also money-wise and research-wise, it's really very beneficial because you can get money from both universities. Of course, you need to be patient with 1 year approximately with the residency. But why to hurry? You will be a medical doctor up to 65 years old or 70. So resident doctors still have 40 years on the row. So 1 year, for changing your next, I think, I wish I were the same age like these guys next to me.
All right, thank you again.
Well, Peter, thank you very much for being with us today and for all your effort during the time and related to education in our field, in medical field, especially in gastroenterology. My question is, okay, first year it's very clear the program. How is built in Hungary the program for people who are in the translational center? I mean, they are residents in gastro, in dentistry. This is 24 hours a day for everybody. So how you succeed in Hungary to put time for research in their curricula, in their time?
Thank you. Very important question, because now the question coming these guys not to attend in Budapest because it's attractive, money-wise, research-wise. The question when they come back, how you can support them. Because for them to give the knowledge they have to the students who are here, they need protected time. You are completely right. So what we did, we had a word with the directors of each clinics. Because these guys, if you want this program here, they will need 1 day per week for giving the lectures, putting together the knowledge for the new generation. So I think like working 4 days in a clinic and having 1 day during the residency for science, I think this could be a very good solution. This is how they do in Vienna as well. In Vienna, in the medical training, it's written that 9 months can be used for science when they are in the program. I think in gastroenterology, this is also written in the gastro-medical training, as you mentioned, to need papers and so on. So I think it's strongly dependent on the clinicians here. If the head of the department would like to support this program, then it will rush even better than at Semmelweis. At Semmelweis, as I said, we had 750 residents. Here you have 3,000. So even the speed can be 4 times higher. But very importantly, it can go only in the subject where the clinical director supported. If the clinical director overload the resident with 60 hours work per week in the clinic, you have no chance. So the real secret is the clinical directors, that's for sure. Okay, I think we can go. Just don't forget to ask the phone number, ladies, from Theodore. He's there. This is the most important part, was my lecture, I think, to find him. And if you have any questions, we are here. And I am super enthusiastic, I must say. And I'm sure we can do together something great. Thank you very much.